So we are discussing the another condition for the differential diagnosis of deep TV inversions in the anterolateral leads. But this, as you can see, that there is only minor changes in lead V1, V2, V3. This is more often seen in females, the juvenile pattern of the like pediatric population, because you know that during birth there the RV will be under pressure of uh, the left side of system of the body, because the RV will be supplying the actual inferior aorta, the transverse aorta and the inferior aorta, and the other periphery of the body, because through the PD it is transition, the blood is blood is getting diverted into the aorta. So the RV will be under pressure. So juvenile pattern will be there, maybe persistent from 3 to 10 years of age, and after that it will be the TOS will become normal in the antral leads, the V1, V2, V3. But this persistence of juvenile pattern is called the juvenile pattern of V1, V2, V3 TO inversions. So here we can see that V1, V2, V3 there is a TO inversion. So now we want to differentiate this from the wellens syndrome. Actually, to be frank to tell, it is very difficult to differentiate, but in this simple slide it is very easy to differentiate. But if it were to be like V1, V2, V3, V4 also TO inversions without any other markers, like the normal TO inversions are also same, and the highly stressful ischemic TO inversions will also be same, the symmetrical TO inversions, there will be no much difference. The actual axis will be normal, there will be no Q waves, there will be no AVR elevation, everything else will be normal. So here also everything else is normal. Only thing is that during the ischemic episode, what happens if the patient's correlation of angina with the STT changes should be very strong. So here the history of the patient takes a very important decision. And another thing is that females and have a much higher incidence of this being TO inversions are common. And if you can take the ECG from the wherever they get, like 10 years back, 20 years back, 15 years back, the ECG will be same. But in wellens syndrome, the transition of normal ECG waves to the TO inversion will be there. Like 2 years back it will not be there, but 1 or 6 months back it started. And now when the ischemic episodes are there, the TO inversions will go off in the wellens syndrome. But these TO inversions will be there even during the stress, during the TMT, and no changes will be seen in the TO inversions. But to be frank, it's a little difficult to differentiate between juvenile pattern and the wellens syndrome absolutely only on the ECG. Okay, this is another ECG of deep TO inversions in the antral lead and biphasic TO inversion in the V4 and V5. You can see that there is a biphasic TO inversion in the V4 and V5. So but here you can see that some other clues are there to tell that something else is going on than just wellens syndrome. There is no wellens syndrome actually. There is a deep Q or a Q, good Q in the 2-3 AVF, and there is a huge R waves in 2-3 AVF. Okay, and there is a good amount of R in the antral lead, and there is a good amount of Q in the lateral leads. Most significantly suggesting that there is dilatation of the LV also, because you can see that Qs are deep enough, and there is a huge amount of R wave in the lateral leads and inferior leads. So either some variant of HCM like the apical HCM will be having similar Yamaguchi syndrome, I will be discussing in future slides, or something involvement of the RV like the VSD, or because of the RV and LV dilatation, or because of the other kinds of AR with TR. All these things can be considered in this kind of ECG, but absolutely not wellens syndrome. Thanks.